Hi, everybody. We're live.
Hi,
Welcome.
everyone.
So, welcome again.
Happy Wednesday to everyone. I'm Emilie Scott at Halcyon Health.
I'm James Gaor.
Shea Suskin. You might not recognize me, full disclosure. I got a backyard haircut this weekend. Feel like a
Really?
new
A
person.
backyard? That's
It's
pretty
still
good.
me. Backyard. She didn't come inside. We
Wow.
stayed outside of my
Hi,
backyard. My
everybody. We're
cousin
live.
cuts my hair, so it was.
Hi,
Welcome.
everyone.
So, welcome again.
Sorry.
Oh,
Okay. I got my sound fixed. Is that
perfect.
okay?
Well,
Okay.
yeah, looks good. Looks like there's a couple people here already. So, welcome, everybody. We are going to talk about a couple things. We'll start off and just some basic overview of where we're at statistically, like we usually do. And then we were going to talk about a little bit about vaccines. So somebody had emailed us and said, hey, there's a lot of news again about vaccines and the hope and stocks going way up. And then the next day, stocks going way down again because of, once again, the roller coaster ride of data and what it does and doesn't show, and give a little bit of a higher level view of the process of vaccines, potentially what they may be able to do, what they might not be able to do in a particular time period. So that's something we'll talk about. Number two, Shea had forwarded an article this morning just talking about kids and their potential infectiousness, infectivity rates. We've kind of alluded to it over the past few weeks about how we're still learning about how infectious kids are and how it affects different groups, and what does this mean for us moving forward? The summertime, camps, school coming in the fall, people being very excited, anxious, opening up business-wise, resuming a sense of normalcy. So all of these things we'll talk about today, and and hopefully answer your questions as well. Cool.
Awesome.
On that note, so we could talk about the data. So there's been a couple changes since last time we talked. I think we've mentioned briefly, we're in this phase 2 now of closure. And so we're opening things up. We're opening up retail. Certain retail sectors are opening up. Restaurants have been opening up with takeout, curbside delivery. There's this next phase of, can we do dine-in? I think there's a lot of buzz about how we do that. And so some of the restrictions are lifting, and there's some criteria coming along with that. Clearly, there's a need to assess at the county level our resources and where we're at. So from the data, we can see that our resources are still available in terms of having beds available, ICU beds, general beds. So that's not something that we're constrained in. It hasn't been something that's been an issue for us, and continues to be something that we do have adequate resources to deal with any potential surge in cases. So that's number one. Another thing that people are, or I should say the state is looking at, is making sure there's no 5% increase in week-to-week case counts. So that's something that we have not seen in terms of a trend. I think our case count, and I'll bring this up here as well, hasn't been increasing in a dramatic way. And also, I believe another criteria is positivity rates, meaning the percent positive out of the people we test needs to be 8% or lower. And in Orange County, we've actually been at 6% roughly, according to some numbers that we were listening to on another stream from the county last week. So all those things are reassuring. Here's some of the case counts per day that I'm scrolling up here. So once again, it's slightly going up, but once again, there isn't this dramatic surge per week. It is steadily climbing. It's not going to be surprising that we're going to see increasing cases over time. Once again, it's really about the rate of increase on a daily, weekly level that we want to just make sure we keep track of. And here's an overall curve of what we're seeing. The testing that's been done, it's kind of interesting. I don't have, and we haven't discussed, why the case counts have, or the tests, I should say, have been lower. But that's an interesting number, why it's plateauing. But we do have tests available, and so I think that's another push that I think us as a practice, we can talk about as well, and making sure everybody is understanding that we have plenty of tests available for everybody in our practice, to be able to test people for the nasal swab test, which I think is an incredibly valuable tool. We also do have antibody testing that is available for also members in our practice who are, once again, curious about antibodies. And we've stressed this over and over again, the limitations of antibody testing. And really, at this point in time, it does not change management. It does not give people definitive immunity based on a positive test. But it is something we're continuing to have ongoing discussions with anybody who is interested in doing antibody testing. And we also will counsel everybody who does want to do the testing to make sure that you are aware of the limitations, the potential benefits, if there are any, at this point in time, and that will always be a changing issue. So those are the numbers in general. You can also look it up at the Orange County Public Health website. But the take-home points are, there's not a surge. It seems stable. We have the hospital resources, and that also helps support all of the decisions that are being made to open up Orange County in a safe and responsible way moving forward. Once again, also keeping an eye on where things are in the future.
Can they see us, or are they still looking at the graph?
They're still looking at the graph, so okay. I should change that. Because I'm looking at you. And she's really narcissistic and wants to make sure that everybody can see us. Just kidding. So yeah, any questions on that? Is that clear? I don't know.
So I think so. Lori's asking if that means we're specifically meeting the governor, because Newsom has been talking about statewide, not just here, but kind of an overall loosening of guidelines and maybe earlier reopening than what he was initially talking about. So do we meet those specific criteria? I don't know if you've looked at that today. I heard some of the broadcasts of him talking about that yesterday, but I haven't looked yet at specifically what changes have been made. Just that in general, there's a loosening.
Right. And so I pulled this up briefly. And so to your point, yes, that's a good question. I haven't looked at the specific directly from the state. This is from, the San Francisco Chronicle. So this is reported from somewhere else. But this was a highlight of, the framework. Basically, the counties having shown no increase in more than 5% in the past week, or no more than 20 patients on a given day. So we're not going to meet that one because every day is more than 20. So it's the 5%. So it's a relative increase based on the county size. And then fewer than 25 cases per 100,000 for at least 14 days, or a rate of positive coronavirus tests that has dropped below 8%. So based on those criteria, once again, I haven't done the number crunching specifically for Orange County, but the positivity rate has been around 6% as of last week. And once again, as you can roughly see from the graph, there hasn't been a huge spike as far as I can tell. And once again, I haven't done the numbers of over 5% on a week-to-week basis. So that's a quick and dirty way of me interpreting the data. So please don't take my word for that. But I believe based on that, it seems reasonable to start planning. And I think plans have been submitted as of the Orange County Board of Supervisors meeting yesterday to basically submitting a plan to the state to opening up the various other industries that do need to open up. So I will leave it to them to communicate their messages on that. Does that make sense? Is that clear?
Mm-hmm. Mm-hmm.
Okay. And yes, Lori did mention they did eliminate the requirement of no deaths for 14 days. So that is not, that was something that was somewhat unrealistic for many counties especially larger counties, to not have any deaths for 14 days, and counties with millions of people. And so that is something that has been taken off the list.
Okay.
So that's the question. So yeah, we're moving forward. I guess in a nutshell, that's where we're at in terms of opening. And so now it's up to our individual counties to kind of work out the logistics of whatever business sector you're in to start complying, and start also drafting how a safe and reasonable way to conduct business, and hopefully get more people out there in once again, a very safe way.
And of course, Jan, tried and true, is giving us some of these numbers. So he was saying 38 per 100,000 deaths from 14 days ago.
Delta.
Oh, change. Got it.
Okay.
So does that meet the criteria? Well, he'll let us know.
Right. So it's hard to say that, but I heard the positivity rate was below 8%. So there's all these qualifying ors. So sometimes we won't meet the absolutes, but on the relative basis of things. So I don't have the data in front of me. I just remember hearing from a live stream from Assemblywoman Petrie Norris that the positivity rate, we went over antibody testing, that they actually had a nice webinar, was it last week?
Yeah.
About antibody testing, and they did bring up the positivity rate in terms of antibody testing as well, and PCR testing, I should say, and the positivity rate has been around 6.3%, if I'm going to pretend to be accurate. So it does meet
Very
that
specific.
criteria. That's very specific. So that's what was communicated roughly, and so that appears to meet that guideline. So once again, I'm not familiar with the specifics in Orange County, but I
And
feel
then we
that's
have James here who's in touch with a lot of this. He's saying that he doesn't think that, a different James, that we've met the criteria yet. He said that we're short on PPE for the skilled nursing facilities. So they're working on that. So
Right.
that's a holdup.
Right.
I
So
guess.
PPE was
Thanks,
not.
James.
Yes, thank you, James. That has been a question as well. PPE. So hopefully PPE is one thing that can be addressed in specific facilities that are definitely at higher risk. So yeah.
One of the things, I just wanted to bring this up because we were talking about availability of tests, and you guys saw on that graph the testing numbers dropping off, and I think the media is reporting, why we need to do more tests. And so I've had a couple people ask me, well, I've been isolated for a long time. I have no symptoms. I have no risks. Should I be getting tested? Because everybody on the news is saying we should test. And so my answer to that is no. If you have no risks and no symptoms and no worries about exposure, then and no plan to be out in the world, then there's not really a reason for you to go and do testing. What we really want to be clear is that people know that we have things available, and we have a very low threshold for testing. So if there's any question, you don't feel well, you're having a symptom, you're not sure what it is, call us, let's talk about it, and let's get you tested, because we have the resources and we can get you guys in. So for both the antibody test and the swab. So you don't have to be a first line responder, you can be anybody, and we can have you come in and we can test you. So I just want to make that clear.
Mm-hmm.
And then yes, clarification I guess was given about the per 100,000 delta has to be under 25 per 100,000 increase change. So that could from week to week as of Tuesday. So that calculation as per that has not been met, I guess, is what's being communicated. So once again, lots of guidelines that we have to keep an eye out in terms of how we position ourselves in terms of planning. And once again, definitely beyond our scope in terms of necessarily being able to address in our practice, but definitely people being aware of these are the plans that are happening to make sure, once again, moving forward and opening up businesses, this is what's being used as metrics for that.
Mm-hmm. Mm-hmm.
So can we talk about schools and teachers and all of that?
That's a parallel.
Yeah.
That's a good
I thought
segue.
that would be good to get back to that. We didn't lose that question
Yeah.
up there, and that's a very good question. If I'm higher risk, I want to go back to teaching kids at school. Everything that we were just talking about is all pointing to, we're all feeling very hopeful that schools will be opening this fall. James, have they made a definitive announcement in Orange County for public school? I think it's still by district, but it's looking very good. I think we are optimistic that will happen. I might just send out here in a second this article so you guys can all click on it that I came across just today about the whole issue of what, again, before I start talking about infectivity in kids, we'll give the disclaimer of the data is still very limited and there's still a lot of question marks. But putting together the few studies that we do have, just studies of random testing in small areas and in countries that have been harder hit, like Italy, and then some other countries that haven't been as hard hit. There's a study from Norway and another one. But in these studies, when they're doing random testing, the numbers, random testing of thousands of people, the numbers of kids that are infected are consistently very, very low. So stepping back, looking at how high risk is it going to be to open schools, to have kids go to summer camps? How likely is it that kids are, that we're going to have this issue of, we might not see a lot of kids getting sick from COVID, but are they asymptomatic carriers? And even last week, I was saying, that's my fear. There are so many other viruses that do work that way, and kids are, it's so hard to control, them touching each other and touching us and not washing their hands. And that is certainly a fear that they could be these asymptomatic little germ vectors. But it's looking like, again, the limited data we have, that's not really bearing out. Their risk of getting infected with COVID just seems really significantly lower. And so as we start looking at schools opening up and things like that, I think the most important thing to focus on is going to be in those settings, really being cautious with and limiting adult to adult interaction. That's kind of the tricky thing. When those things start to open, it means that more adults need to be together in those places to make it happen, to teach kids. And if we can be creative and thoughtful about how to try to maintain 6 feet of space and appropriate precautions and all of that between adults, that's going to be the priority. And still being as cautious as we can with kids. It is true that that kids can get infected, but just on the larger, public health scale, it's so much lower than adults. And so it just, it's giving us a lot of, the limited data we have is giving us a lot of optimism about moving forward with those kinds of things.
I think it's fascinating, right? I think I read that article, you sent it to us this morning, so thank you for that. And how, once again, everybody's part of this learning process. We come to this with many assumptions, and one of the assumptions we came into this is that kids just give viruses and are little virus vectors
right.
as before, and kind of what you've alluded to, some preliminary data has suggested that it's different in that, yes, they are once again less infectious. In general, the severity of this disease, it's much milder, and so there's lots of theories about how that's related. And we do want to put it out there. It's not that kids can't get sick, and you mentioned that already. It's just very different than what we're used to. And once again, this is very preliminary data. And right now, timing-wise, we do have a little bit of I don't know if luxury is the right term, but we do have the ability to see how it pans out elsewhere in areas and countries that are quote unquote ahead of us in terms of where they are in terms of their disease process, in terms of they're going to start opening up schools, so they are going to see that before we do, and so we can learn from each other and actually collaborate and say like, wow, this is what works, this is what doesn't work. But it is reassuring, and I'll repeat that as well, that it seems that the infectivity rate of children in general are different than adults. And once again, going to your point, it's the adult to adult transmission that seems to might be the focus as we start to open up schools and daycare centers. How do we optimize that? The CDC released their 60-page guideline of opening up this past weekend, pretty quietly, but it's there. I actually just downloaded it today. I have not gone through and read the details of it, but there were some summary points about when you go back to school, what are some of the recommendations for kids in terms of potentially social distancing. Clearly the hygiene aspect is part of it, but it is going to be interesting to see how we develop these policies in schools. And I am optimistic as well that kids will be going back to school potentially this fall. I'm not saying it seems like around the corner, but it's still pretty far away. But there's to me some optimism that kids will be going back to school to a certain extent.
Does it seem to me, and I've been a bit busier seeing patients and stuff, so I haven't done as much reading as you guys have. But does it seem to you guys that a lot of this is about bringing things outside? Like Shea got her hair cut in the backyard. There's some small risk associated with that because you can't really social distance. Do you have your class in the outside? I was just speaking with someone who's higher risk, and can you have an outdoor picnic with someone, and that's lower risk? And it seems like we're here in California and we have great weather, and if we could just get outside, it would be a little bit lower risk.
That seems like a great great idea. And to be honest, my personal opinion, I think kids should be outside anyway. So if somehow schools can adopt that in terms of like, hey, it's actually good for multiple reasons, and vitamin D, which is, whatever, a good thing. But kids just being outside, playing outside, learning outside, if there's, once again, that's a luxury for many, for some people. But is that a contributing factor? It's possible. It makes sense from a germ theory, like, instead of being enclosed in a room. Seems like a reasonable theory.
Yeah.
Right.
Jan's giving us more data. I think Jan is very mature in his ability to handle data. So
calculators are confusing for me. So
yes. So I don't know. Can everybody see this?
Yeah, everyone can see it. Yeah.
Okay, so I'll let you guys interpret that. I don't.
Yeah.
Maybe Jan, you can interpret to us. It seems like from what you're saying here, we don't really meet the criteria based on
that one, or once again,
Newsom's saying.
Or there's a rate of positivity or rate of positive, which is a percentage rate. So
that 8%.
Yeah. But once again, I don't have those numbers, but I think that's definitely being looked into in terms of making those decisions.
Should we talk about vaccines now?
Sure, unless there's more about schools or kids and daycare you wanted to talk about, Shea.
No, not necessarily. Just wanted to give the little update because I feel like last week, we did touch on this last week in terms of camp and things that kids can do. I feel a little pessimistic about it last week, and this article made me feel a little differently seeing the data summarized like that.
I think, schools are planning to do the best to open this fall. And I think schools are, have to plan in terms of, some schools have made a pretty quick decision about moving it to online. Universities, the Cal State system in particular. But once again, it's a local decision that has to be made in terms of what's best for their community. And I know that definitely there are schools out there planning to bring kids back to school in a physical way. Some are doing it in a hybrid way. Once again, this is a work in progress that we're all learning at the same time. So if we can appreciate that and understand and be patient with each other about that, I think it's going to be the biggest help instead of necessarily criticizing, but really we're all just trying to figure it out. And once again, coming from a place of making sure it's the best in terms of safety, education, no matter what sector we're talking about. The intention is based on wanting to be better. So, yeah.
Makes sense.
Okay, cool. So vaccines. Who's getting a vaccine for your COVID?
I think we'll be ready by next week.
Yeah, next week, I think. No, so there's lots of talk. So, I don't know if you guys have read the news, right? So Moderna is one of the pharmaceutical companies that had released a statement saying that they had some signs of, that they were able to elicit an immune response. So we talked about it briefly. I think just talking about vaccines and like what's realistic to expect, like what's the process of making a vaccine? Did you want to talk about that in terms of the high level of vaccine course? And
right.
Does it take a year? Does that seem pretty reasonable? Or I've read it's 5 to 10 years.
Right.
Tell us.
So to give you, and maybe this is too much detail, but the way a vaccine is made, there's different kinds of vaccines. So there are the kinds where they take the virus itself and they basically disable it or kill it and then inject you with it, and then your immune system responds accordingly, and then you're safer were you to get exposed to the full potent virus. And then there's also these vaccines where they tag this, they call it messenger RNA. So it's almost like a little signal to your body to start making the protein that's in the virus. So it's tricks your body into creating just a piece of the virus in your body so that your immune system then responds to that protein. It sounds like science fiction when you talk about it like that.
Weird.
So that's kind of the first step, and maybe Shea and James, you guys can help me with this. But the vaccines, the method of vaccine that they're looking at, that Moderna was it an mRNA?
Mm-hmm.
Yeah. So that was that more science fiction-y thing where they give you this this thing that makes your body make a protein that looks like the virus, and then your immune system responds accordingly. And so they've been able to do that. And then after they do that, then they have to test it in people and see if their immune systems respond accordingly. And my understanding is that they've already had that happen, right?
So that's the question. And so this is, the backlash after the initial positive result was that if you look at it, so basically what they did was look for antibodies, neutralizing antibodies, in people who received this trial vaccine from Moderna, and compared it to people who recovered naturally from COVID, who just had the disease, recovered, and then basically compared the vaccinated people to the people who naturally recovered. And the statement is that, it's 8 people, I believe, so a very small amount, but they had the same amount of neutralizing antibodies is the statement. And once again, I have not looked at the data, so I'm just interpreting this from other people's interpretation, but that just says that they have the equal amount or similar amounts. But the question is, do people who naturally recovered from COVID-19, this small amount of people, actually have a lot of neutralizing antibodies in their system, or was it actually relatively low? So we actually don't even know what they were comparing at this point, as far as I know. So there's still a lot of questions as to what that statement means in terms of moving forward. And so one of the things to point out too that Emilie was mentioning about the different vaccines, this mRNA platform is very, it seems relatively quick to deploy and scale. The one issue is it's never been done before for a human vaccine. So this is a totally new platform. So people once again are putting it on the microscope to say, hey, that's encouraging that we're developing this. This is the first time this could potentially, if once again it goes through all the various phases, that a vaccine will be created using this technique. So that's another question for people to kind of chew on at this point in time.
And so you guys know, when James keeps saying neutralizing antibodies, what happens when you get a virus is your body creates these tags on it, which is the antibody, and we've talked about antibody tests a lot. But what a neutralizing antibody, what that means is it just marks it and says this is foreign, and then your immune system can come and take care of it. So it's almost like tagging, this is trash, this is not, this is trash, this is not. And so it kind of it tags the immune system to go take care of business. There are antibodies that can come and start a whole inflammatory cascade, which is more problematic, because inflammation in its best form is our body trying to heal, but when it's overdone, it can create a lot of symptoms and problems elsewhere in the body. So there's been talk of vaccines, particularly SARS-CoV-related vaccines, which this is a SARS-CoV-2, and there's a SARS-CoV-1 that we've tried, and MERS, these other types of coronaviruses that we've tried to make vaccines for, where they've actually, when they injected the virus itself, it created this antibody response that was overblown and created actually more problems. Because you guys think about these people who don't do well are the ones who have this cytokine storm, this almost overabundant reaction from the immune system that makes everything just shut down. It's like we talked about the firemen coming in and just they spray your whole house with the fire hose, even though the fire's been gone for a long time, and they destroy the whole house. So that's kind of what we're wanting to make sure, that we don't create a vaccine that then creates this explosion of immune response in your body, which is a real concern. So one of the other things that they talk about with this is, in order to test the vaccine, you have to give it to people, and then you have to see what happens when they're exposed to the virus. So if people are in isolation or quarantine and the rates are dropping, then people are not going to be exposed to the virus, and thus it's very difficult to prove the effectiveness of the vaccine. So then becomes this ethical question of, can people volunteer to then, they call it a challenge test, where they give you the vaccine, and then they basically throw COVID at you and see how you do. So I don't know if you guys want to talk about that sort of. what's going on with that.
Yeah, so that's a real ethical question. So a higher view of things, there's 4 phases technically of vaccine development: phase 1, 2, 3, 4. First one is really just very small, 10 to 100 people, really just seeing if there's any grave safety issues, and if there's some sort of efficacy response. Phase 2 is a larger pool of people, and once again, it's targeted towards more inclusive of the study target of people who you're going to vaccinate. And then phase 3 is when we start getting into tens to hundreds, thousands of people in terms of trialing it and seeing, is it effective, is it safe? And then 4 is mass market. What Emilie is pointing to is the fact that, and she just alluded to, is, if everyone's in isolation, if we're trying to keep this virus at a low level, it's really going to be challenging to test. Once you vaccinate 1,000 people and just let them go around, it's going to take a while before certain people can potentially be exposed to the disease. So there's this notion of human challenging, which is people volunteering, clearly of their own volition, to say, hey, I'm healthy, I want to contribute to science, give me the vaccine, and then, or not, or give me the control, which is nothing, and then, give me COVID. And so not only is it an ethical issue, because typically human challenges are done when, there's treatment, meaning, okay, if you get it and you get sick, oops, let's cure you. The vaccine didn't work. Right now, that's not the case. There's question about how valid that argument is, and the bioethicists, which are clearly discussing this fervently right now, are going back and forth about how to potentially approach this. But that would be one potential way of speeding up vaccine development in that phase 2, phase 3 of having a pool of people receive the vaccine or control, which is no vaccine, and then actually getting the virus. So there's that piece to it that is being discussed. And then there's the logistics, right? I mean, and Shea, we were talking about this earlier about, this is all great on paper, but how does this happen, right? So there's 100 and something vaccines that are being developed in parallel. What's the onset? Like, how long does it take for a vaccine to come from idea or discovery to deployment usually, Shea?
Oh, I mean, it averages like 10 years, right? And the fastest that it's ever been done is 4 years. That was in the 60s when, safety standards were a little lower. So, yeah, I'm glad you broke down the 4 phases like that, James, and I hope you're all getting a sense of, how very complicated this is. So I think those are kind of just some of the big picture points to keep in mind as you're seeing these news updates and seeing people quote 12 to 18 months. I mean, maybe, but this is tough. It's something, the way that this novel coronavirus has spread like wildfire globally. We've just, a pandemic of this scale is like, we've never seen this. So what James was just getting at too, the way we would have to scale this once we jump through those first 3 steps, and then you're trying to mass produce and distribute to, the entire
world.
It's never been done before. And it's so important to not skip any safety steps for something that's going to have to be deployed so universally like that. So it's a tricky balance. I mean, we're all very, it's amazing how far so many of these companies have already been able to come. And, vaccines are definitely the most effective public health tool we have. It's right that we're spending all this time and attention on this. It has always seemed to me like it would be likely that we'd come up with better treatments, that we have a better understanding of how to use and are more effective, and better contact tracing and ways of limiting the spread of the virus. It always seemed more likely that those would come first before a vaccine was developed. And now, I mean, it is really amazing how far vaccine development has come so quickly with all the money that's being poured into it. But it's all still a long shot that all of these pieces would fall into place. So it's also good that those different, treatments, effective treatments for COVID, tons of studies are being done on that as well. We're trying to figure out how best to limit the spread. All of that stuff needs to be done in parallel. Sorry, I'm kind of steering away from vaccine discussion now, but yeah.
No, yeah, I agree. I think there were a couple interesting ways that people have described it, right? I mean, is it possible that we can have this in 12 months? It's possible. Is it likely? Really challenging based on everything we discussed about, literally from logistics of supply chain. You're talking about millions to tens to hundreds to billions of vaccines. There's things about, unfortunately, a global competitive market where instead of necessarily as much of a cooperative environment, and hopefully that'll change, who has first dibs, right? So there's that question, like if a certain country creates it and it's effective and safe, do they have first dibs? Who gets it? So there's a lot of just logistics behind such simple statements of just getting it out there. It's unprecedented how much money is being put into this. And so that's what makes it possible. But once again, when you look at all the steps that really need to go right to make this happen in such a short amount of time, that is such challenging odds. And once again, I'm not saying it's not possible. It just seems incredibly challenging, and there's a lot of resources putting into it. So once again, we've come a long way in such a short amount of time. I think it's just also really important that people also appreciate that shortcuts are going to have to be made in order to, if there's a deadline, we should always be mindful of what shortcuts are being made, and we really have to make sure that people can look at the data very critically in making these decisions moving forward as to, is it effective? Is it truly safe? Like, what are the conflicts of interest in developing and distributing any of these things? And so we just have to be, once again, be very cautious about it. But that's where we're at. So the bottom line is it's so early. I mean, there's these news things, they just, they're so dramatic. But once again, we're talking at best like a year. That's something.
A year from now, or a year from?
Well, maybe a year
February,
from January or February, right? Maybe.
Well, that's not very long from now.
That's not very long from now. But then you're talking about deployment and like all this stuff. There's a great sentiment out there. Let's say this happens. Is there a realistic expectation that once this vaccine is out there, that we will have this sense of normalcy where we were 3 months ago? And I don't necessarily think that's a realistic expectation either. And, not that it's going to be bad. It's just, we have to think that this world is continuously changing and that, the businesses aren't, once again, we're just not going to be exactly where we were 3 months ago, 4 months ago, even with a vaccine out. And so we have to have this different mindset, this whatever you call, some people call it infinite mindset of, how do we continue to adapt to this change, to this uncertainty? And once again, we're very resilient people, or sometimes one term I like is anti-fragile, which is a great term. You don't just stay the same under stress, you actually get better. So that's the hope, is that, these stressors can create this sense of anti-fragility in our communities.
One of the things I was going to say is one of the shortcuts is that challenge, the human challenge they're talking about, where healthy volunteers come, they get this vaccine, and then they get COVID sprayed at them. And so that shortcut, they actually have, there's an advocacy group, it's called One Day Sooner, and they have 23,000 people that have already volunteered to do this. It's over 102 countries. So there's people out there pushing this shortcut already. So what I really want to look at is what are the shortcuts they're taking, and there's a lot of discussion about the ethical implications of that. What does that mean? And a lot of it is, these are lower risk people, and you would make sure you'd have to build a whole separate facility in case they got sick, and make sure you care for everything that happens to them. And what they even do is they start with a low dose and they give you more and more to make you sick or to make you get symptoms. It's and see how you respond with your antibody response with the vaccine that you got. So it's interesting to see that. And I think as we look at when this comes out the other side, the safety of it, I really want to know specifically what shortcuts were taken and what that means as far as taking that vaccine for myself or my family. And then the other part of that, I think I'm going to lose it. There was another part and I just lost it.
Well, I was going to say like the benefit risks of all of this stuff. And, to Shea's point, I think there's a lot to be said too, not just, the vaccine. I think there's a multi-pronged approach to how we're dealing with this. Vaccination is one avenue, but also, developing treatments, developing contact tracing, how do we restructure some of our living and lifestyles, temporary, permanently, businesses like Twitter and Square are now permanently work at home optional, right? Or go to work optional, I should say. So, things like this, which, are still kind of small relative to the grand scheme of things, but, things are changing and adapting. And, the vaccine, Fred just mentioned, what's the flip side where there's a good possibility that there'll never be a vaccine.
That's what I was going to talk about.
Right. So I don't know the probability of that. Is it possible? Yes, it's possible that there's no vaccine, but then that also means that we have to react to that and structure our lives differently. Treatments, I think, will be more advanced as time goes on. There will be better systems in place to handle that. And so, yeah.
I was going to say, that's what I was going to say where I lost it, was that, some of these things, like you think about HIV or malaria, we never really were able to develop a vaccine. From what I was reading, that people are more optimistic they'll be actually able to develop a coronavirus vaccine that's successful because they've been able to do that for animals. So there's more hope than there is not hope as far as vaccine development for COVID-19. As a timeline, I don't know, but an eventual.
The timeline's a big question mark, and then also that impacts once again, the whole development of disease, communities. I mean, if we're talking 10 years out, by the time that's available versus 5 years versus 4 years, a lot of things change in that time. Versus a year. Once again, weighing probabilities.
You never know.
Never know. So we'll see. I'm not putting any money on it.
You guys mentioned this, but we did get this nice head start of, having these other novel coronaviruses that a lot of research has been done on vaccines, SARS and MERS. It's concerning that the initial vaccine that was developed for MERS, exactly like Emilie was talking about, caused this, activated this inflammatory response. People got more sick. So it, we had a head start. That's something that's helping. It makes it more likely that we will be able to develop a vaccine on this, but it also reminds us of how important it is to not skip safety steps, in trying to do it so quickly. So,
yeah. And I think that's the big takeaway. So once again, let's keep hopeful and optimistic. But it's definitely not anytime, imminently, like next week or anything.
It's next week.
If you want to be a human challenge subject.
No, I'm good.
Yeah, they have to build like a biohazard level 3 structure for these people, right? So talking about that again, I don't know why. I think it's just really crazy. But yeah, for anybody, if this actually does happen, imagine having to do this in a way you're actually creating a pool of people with active COVID. So you definitely have to create, infrastructure for to handle that appropriately, and staff to observe and treat and all these things. I think it's very resource intensive. Not to say it's not worth it. It's just a lot to think about in terms of deciding whether or not to pursue that.
Let's see. Once the vaccine is developed, how will you determine the shortcuts that may have been taken? I think, when I was reading about how they can make this happen faster, there, a lot of it is FDA approval and you get into some of this, some of it is slow for the, bear with me as I use very judgmental terms, for what I see as the right reasons. We have to give this to a person and make sure they don't develop, a nerve problem 6 months later that's irreversible, right? So that's one thing that should be slow, and we should be careful. But the bureaucratic, pushing it through and stamping this paper and stamping that paper and sitting on someone's desk and they're on leave and that kind of stuff can get pushed through, and I actually think that can save a lot of time. So a lot of the authorization process in the FDA, if they prioritize it, expedite it, it can happen a little bit faster. So those shortcuts I'm more comfortable with than the human safety shortcuts. And the other thing was the human challenge. ethically, I think if there are people who are volunteering and it's lower risk and that can be a shortcut. I don't see that as like a dangerous shortcut. It's not like, right, we're not going to sanitize things and then things will go faster. So that's kind of where I'm standing with looking at risk versus benefits of how quickly they bring this out.
Yeah, I just hope, once again, I think like anything, transparency in the process. So as things develop, we as a community should be able to have full transparency in data and how methods were used in terms of conducting tests. And once again, this is a whole multidimensional problem going all the way through the supply chain of creating, shipping, distributing, all of these things. There's various shortcuts that can, I'm sure, happen at those points, but I think clearly we have to have people who are very specific to each of these to really understand what shortcuts are being made and to be transparent about that. So that's what we can hopefully have and trust in the future. Yeah, and then something about so if they're lying about Moderna testing, how can we trust anybody? I don't want to say that they were lying about their testing. I think once again it's an interpretation, right? So we hear certain things, positive, negative. We oversimplify certain results. I don't think they were necessarily lying about the results. I think it's just, once again, having the right context of what those results truly mean, and that's what we've always tried to bring to people is, there's a lot more gray than sometimes people will want to talk about because it's uncomfortable and not as satisfying. So, I don't think they're necessarily lying. Yeah. Yep.
Any other questions out there? Anybody have any questions?
No.
Shea, do you have anything else you wanted to bring up?
Not necessarily. So what we're going to focus on today is mostly the vaccines.
Yeah, and once again, we're available as always. Testing is available, widely available. There have been a couple people, and we forgot to mention that. So we updated our newsletter to reflect that we are actually testing people far more liberally than before. It's definitely not. There's no shortage in our office for it. So if there's any concerns, please contact us. We'd be happy to discuss. Getting you in if necessary, and we're available. And also our office has always been open, but I know more and more people now are feeling more comfortable coming to us in terms of if there's something they want to be examined in office for, which I think is definitely appropriate. Please contact us. We are able to see you in the office. And once again, just to reiterate, we have our infection control policy in place. Everything is clean. We're not letting, there's no and there's nobody like waiting in the waiting room. There's no shared space like that. We're asking people to wait in the cars. So it's a very safe place for people. If you need to be seen, want to be seen, we can definitely see you in the office. Cool.
I was also going to say too, when you want to come for your physical or routine care, we're trying to do as much as we can over the phone first. Okay. So if you're uncomfortable with that, just let us know. But we're trying to set up a phone visit, talk to you about what's been going on with your health and routine things, and then set up the office visit after that to shorten the face-to-face time, just because less time spent in a mask for all of us is probably more comfortable.
Good point.
So just keep us posted on how we can help you work that too.
Yeah, and so also too, Spruce has a cool, if you're on Spruce, most of you are, there's a cool video thing. I actually haven't used it, and you've used it a couple times. So it's also built in.
Yeah.
Yeah, it's super cool. So if you want to actually see each other in two-dimensional way, then that's appropriate.
Yeah. Elaine had a good question, and I brought this up a little earlier too. Should you get tested if you have no symptoms? So if you have no symptoms and no risk of exposure and no concern that you could have been exposed to COVID at all, then I don't know if you really need to get tested. If you're working in an environment where your office has decided to do regular testing, or as things open up and employers decide how to use testing for people who are interacting more with the public, then that's a different thing. But Elaine, from no risk, no exposure, I wouldn't want you to come out of your house to do a test if there's no reason for that. So
reasonable, yeah. And like you were saying too, there are some businesses that are They're considering doing regular, COVID swab, nasal swab testing. This is once again a work in progress, so you're going to see a lot of places do things differently. Everyone's trying to figure it out. What's the best practice? What's the best use of testing, screening? People are doing temperature checks at various facilities, whether it's school, office. There isn't a perfect answer at this point. Once again, we're all just trying to do the best we can in terms of making sure everybody is safe and feels safe. So we're just going to have to roll with it. I think there's, once again, we will see as time goes on what the best practices are, not only here, but maybe elsewhere in the state, country, world, based on experience.
And we're working on the magic wands, Dina.
Yeah, I was going to say, we'll get back to the magic wand data next week, I guess.
You can get it on Amazon, I think, if you search for COVID magic wand.
My daughter's got a few in her bedroom. Maybe it's in my mouth.
Just have a coronavirus, ball on top.
Yeah.
Sounds good.
Awesome. All right. Well, I guess we'll call it then, since everybody seems happy with that or confused.
So.
I don't know. Either way, we're leaving. We're done.
Email us if further questions.
Yes, you know where to find us.
Yep.
So thanks for watching, and
Next week.
we'll see you next time.
Bye.
Bye.
Thank you.